All right, welcome to the Oregon Poison Center's 2025 National Poison Prevention Week Healthcare Lecture on Psilocybin in Oregon. This webinar is being recorded and will be posted to the Oregon Poison Center's YouTube channel in the coming weeks. Questions for our presenter will be addressed at the end of the presentation as time allows. Ann Duncan, nurse manager from the Oregon Poison Center, will facilitate the Q&A at the end. Our speaker today is Dr. Shana Kusin. Dr. Kusin is an associate professor of emergency medicine and medical toxicology at OHSU. Her academic areas of interest are psychedelics, narrative medicine, and physician wellness. When not at work, she can be found knitting skull-themed cozy things, chasing around her daughter and their two dogs, and occasionally lifting some heavy weights while listening to loud music. Please join me in welcoming Dr. Kusin.
Hello, everybody. Nice to be here in this very unusual world of virtual presentations. Speaking to my home rather than all of you directly, but luckily I think I've finally gotten a handle on virtual presentations. I have to laugh because I did not update my bio for you 3 days ago when I got a third dog. So, what can I say? But let's go ahead and jump into this topic that is, I think, pretty interesting and exciting to a lot of people in healthcare these days, myself included. So first, of course, the obligatory disclosure. I have no financial disclosures to report. I now have another cute dog I could have included. This is the second dog, Minnow. Let's go ahead and jump in, however. All right, so psilocybin, of course, and psilocybin mushrooms have been around and part of the human experience for centuries. There are over 100 species of psilocybin-producing mushrooms, including some non-psilocybin species. But this picture here was found on the wall of a cave in Spain. It's felt to be the earliest depiction of psilocybin mushrooms. It dates to about 6,000 years ago. Of course, the psilocybin mushrooms have been widely used in religious and ritualistic practices by Native people throughout Mesoamerica. This is just some old artwork that depicts psilocybin containing mushrooms. There's a lot of art suggesting that the psilocybin mushrooms heavily featured in Montezuma's coronation in 1502. But of course, today our focus is going to be on the modern era. This really started in 1958 when Albert Hofmann was able to isolate the psilocybin molecule. There was some preliminary research done throughout the 1950s and 60s, most notably by Timothy Leary and his colleague Richard Alpert, who later went on to be known as Ram Dass, as part of the Harvard Psilocybin Project. And this coincided with a time when there was a lot of popularization of the entheogens. These are drugs that were felt to kind of alter the perceptual experience. Individuals like the Wassons. Gordon Wasson was a VP at JP Morgan, and his wife was a pediatrician and ethnomycologist. They went on this big search for mushrooms throughout South America, and Life wrote a story on it. There were, popular figures like Terence McKenna and Robert Anton Wilson, who were all talking about the sort of subcultural use of psychedelics. Of course, all of this ends up culminating in the Controlled Substance Act of the 1970s, when drugs became illegal and essentially all research ceased. That's where we were for several decades until 1992, when the National Institute on Drug Abuse and the FDA Advisory Committee opened the door for the resumption of research with psilocybin and some of the other psychedelics. There was some compelling initial literature that came out in like the early 2010s showing this really impactful ability to change cancer patients at the end of their lives experience of their final days with psilocybin. All of this leading to, in 2019, psilocybin received a breakthrough therapy designation from the FDA. And in 2021, the NIH issued their first grant in over 50 years. This was a $4 million grant given to Johns Hopkins and the University of Alabama to study the effect of psilocybin on smoking cessation. Um, and this is where I always pause and say, as an emergency physician and a toxicologist, who started my toxicology career in 2011 when I moved to Oregon from the Midwest, when this was sort of the times of marijuana being legal for medical uses, but not yet recreational. I've sort of always had this reflexive skepticism about a lot of these concepts and have been curious about, what's real science and what is people just looking for ways to make drugs of abuse that are perceived to be pretty low risk legal. So I was intrigued during my training, having encountered some of these earlier papers about the end of life cancer patient experiences, and then in 2019, as psilocybin's getting back out into the world. And then, of course, in 2020, when we all of a sudden have something to vote on as Oregonians, are we going to be the first state where we have some degree of legalization for specific treatment scenarios? This is when I thought to myself, okay, I am obliged to go start looking into this. Is there any actual rationale behind this? Or is this just a bunch of hippies trying to get their favorite drugs legalized? And this is when I developed an interest, because I thought it was very surprising, some of what I learned about not only research supporting using psilocybin for therapeutic purposes, but also really sort of a mechanism that made sense to me. So that's what I want to share with you all now. First, let's just, get some of the basics covered about pharmacology. So we'll talk about psilocybin, which is this molecule. It is a naturally occurring member of the indole alkylamine class of hallucinogens. We're actually, however, talking about psilocin, its active metabolite. Psilocybin can't cross the blood-brain barrier, psilocin can. What happens is that it undergoes first pass metabolism in the liver, it's dephosphorylated into psilocin, then it can have its active effects. Even if you are not a big organic chemist, you can see right here, interestingly, the molecule of psilocin really does look a lot like serotonin and tryptamine. So you can see there a basis for where it might have some similar effects. So when we're talking about ingesting psilocybin, which then is converted to psilocin, you can expect an onset of about 30 to 40 minutes. It's going to last 4 to 7 hours. But of course, there's a question of a dose, right? So if we're talking about a mushroom, how much does it take and how can we be consistent about this? So a dose of about 0.4 milligrams per kilogram of psilocybin will lead to intoxication. That is roughly 1 to 2 grams of dried mushrooms. 0.4 milligrams per kilogram is somewhere in the 28 to 30 milligram range for a 70 kilogram adult. When we go look at a few studies in a little bit, you'll note that most of them use like a 25 to 40 milligram dose. So the goal is some degree of intoxication. It's worth noting that the lethal dose in rats is hugely larger than the dose we're talking about for intoxication. So that's a very large therapeutic range, which is great, right? It's really hard, if not impossible, for a person to overdose on psilocybin before they're so intoxicated that they're going to stop ingesting it. All right, just a few slides about mechanism, and I'm going to try to keep this light with the goal of us all just sort of believing, as I do now, that there really is a basis for why this might be such a helpful agent. So the major site of action of psilocin is that it is an agonist at the 5-HT2A receptor. These receptors are richly distributed throughout the thalamus and regulate sensory input. The thinking is that activation of those 5-HT2A receptors decreases thalamic activity, which leads to alterations in your sensory perception. However, psilocin has activity at many other sites as well. It actually binds most strongly at these 5-HT 1D, 2B, and 2C receptors, impacts all these other receptors as well. The general gestalt is that, the psychoactive properties of the visual and perceptual changes are probably due to partial agonism at that 5-HT2A receptor, but its unique ability to impact so many other aspects of the brain probably has to do with all of those other receptors that are involved. It's worth also talking just a little bit about its activity at the dorsal raphe nucleus and the median raphe nucleus. Psilocin is a partial agonist at these 5-HT1A receptors. The dorsal raphe nucleus is one of the largest serotonergic nuclei in the human body, and it very significantly innervates the forebrain. The median raphe nucleus helps with memory consolidation because of its projections to the hippocampus. So what happens is when psilocin binds those presynaptic 5-HT1A receptors in the dorsal raphe nucleus, it changes downstream activity in the locus ceruleans. This probably has pretty significant implications on how psilocybin helps the brain speak differently than it does otherwise. Interestingly, the 5-HT1A receptors don't seem to downregulate the way that we can see receptors do when chronically exposed to pharmaceuticals or to drugs. 5-HT2A receptors do tend to downregulate. But what this means is that there doesn't tend to be tolerance that develops over time. So what does all this mean? This is, I think, a really fascinating illustration that was generated by a computer in this paper back in 2014. Because of these huge changes in the way that the different parts of the brain talk to each other, partly because of turning off the dorsal raphe nucleus and then allowing all these other pathways to open up. On the left here, picture A, this is how the brain normally communicates through its circuits. And this depiction on B is all of these crazy new pathways opened up in the setting of psilocybin. And in fact, this paper came out pretty recently looking at a bunch of functional MRI images of individuals using psilocybin over time. I myself am a terrible neuroscientist, and I often kind of end up with my head swirling looking at stuff like this. But the take home is pretty cool. And really, the title of this paper, Psilocybin Desynchronizes the Human Brain, hits the major points. So, what the authors found was that psilocybin very significantly disrupts functional connectivity, which is the FC on this graph here, in both the cortex and the subcortex. By significantly changing the connectivity, the brain essentially desynchronizes in spatial scales and changes like the default settings in the brain, particularly those connected to the hippocampus. And these pathways are pathways that are thought to be a big part of our sense of space and time and self. And they used as their comparison drug in these pictures, the MTP is methylphenidate. And so they're just showing, individuals receiving no drug, individuals receiving methylphenidate and receiving psilocybin. And they showed this like massive change in pathways and all of these very fundamental kind of who you are and how you see the world pathways after doses of psilocybin. And they found that the changes persisted for weeks. So, pretty cool in my opinion. Also worth mentioning, I think not a lot is understood about this additional aspect of psilocybin, but it's certainly intriguing. Um, as far as dopamine goes, psilocybin seems to have minimal impact at the D2 receptor. The D2 receptor is one that's associated with psychosis and with motor function. And indeed, we don't tend to see people having a psychotic reaction to this particular medication. Um, it doesn't seem to have a clear impact on the mesolimbic pathway, which is thought to be why psilocybin has historically not showed much addiction potential. And I think a lot of us in healthcare, even without knowing tons about this particular drug, it intuitively makes sense, right? We don't see patients that we think of as quote unquote addicted or dependent on psilocybin. Finally, psilocybin has a lot of activity at this D3 dopamine receptor. It's a receptor that's not well understood, but to the extent that psilocybin has been shown to potentially be extremely beneficial in treating addiction, there's speculation that its activity at D3 may be part of why it can help break some of these addiction pathways. So with this as the basis, we dive into the new and ever expanding world of EBM, evidence-based medicine, and psilocybin. Um, this is an area that is, of course, wildly popular right now and garnering a lot of interest. I mentioned that there were some earlier studies showing this really profound impact on patients facing the end of their life, reporting that they felt less anxious, they felt more at peace, more one with the world. There's been a lot of work specifically showing, you know, applications of psilocybin for treatment of major depressive disorder, PTSD, obsessive compulsive disorder, substance use. In fact, if you go and look on clinicaltrials.gov, I did this a few weeks ago, there are currently 221 ongoing studies looking at different applications. So I know I personally, if I'm in a talk and somebody just starts rattling through studies, my eyes roll back in my head and I have a hard time paying attention. My goal here today is not to just bludgeon people with studies, especially because there are so many out there. I'm going to give you just sort of a really fast dog's head out the window kind of overview of a few interesting ones. But there are some things I want everybody to keep in mind as I go through these studies. There are, you know, I'll say this, I think a lot of times throughout this talk, like psilocybin is still not legal for clinical use really anywhere in the country. We'll talk some about what's happening here in Oregon. But so all of these studies are extremely controlled, limited situations that are designed to kind of build a basis for us, you know, hopefully being able to expand the therapeutics. There's a huge enrollment bias present in almost all studies. And when I say enrollment bias, what I mean by that is that people, researchers, patients are incredibly excited about psilocybin. And this comes up again and again and again in papers. So people who are signing up to do these studies are coming in really believing in the drug, begging to be put in the psilocybin group, feeling highly motivated to do the study. So there's sort of this like positivity bias or enrollment bias where I think people are really looking to feel better and find results. So that is something that can always color participation, especially if we drop down to actually item number 3, which is placebo control issues. It is incredibly challenging, if not impossible, to blind people to psilocybin because it causes intoxication. So there are different ways that studies try to account for this. I'll talk about that a little bit as we go through some of them. Some researchers have used niacin because it causes flushing. Some have used Benadryl because it can cause sort of delirium, not delirium, but you know, makes you out of it. Delirium in large doses make people feel a little bit dizzy. But generally, individuals know if they've received psilocybin or not. So that is certainly challenging when you're dealing with people who are excited to be there doing this and motivated to report positive results. There are lots of issues with study populations. And this is addressed widely. I think a lot of researchers do the best they can, but you know, there's some kind of recruitment bias for who is responding to psilocybin studies in these urban centers or at academic centers. So worth noting. Also, there are always generalizability issues. All of these studies are, highly controlled, very ideal situations where individuals are generally receiving the, psilocybin plus then either a placebo or something else, and they're being monitored very closely, having really intense, repetitive application of questionnaires and therapy. And this may not generalize quite as robustly to the real world. In addition, a lot of the earlier studies are individuals who, for safety purposes, were weaned fully off of any of their psychiatric medications before being able to start these studies. And so there's, immediately calls into question how ill some of the study populations are, compared to, somebody out in the world who has very serious crippling depression, for example, and can't go off of their meds to do a psilocybin study. So with that said, I just want to share, oh, nope. I also want to talk about one thing with you before I jump into studies, which is just to explain to you what these treatment sessions are. I know this is not something I could easily wrap my head around when I started reading these studies, and ended up asking a few questions that felt extremely simplistic and a little embarrassing to some researchers. But a psilocybin treatment session, and this is what's done in studies. And when we talk about what's happening in Oregon, also that model is being used here. So a session lasts anywhere from 5 to 8 hours. An individual has somebody with them the whole time who is a facilitator. This is someone who is trained in keeping the patient focused on the experience and asking them questions to kind of lead them forward and have them synthesize what's going on, also respond to any physical side effects that may come up, like nausea or anxiety. Generally, the patient has not sensory deprivation, but very limited sensory input. They'll wear kind of an eye mask. Often there are sound blocking earphones. Maybe there's relaxing music playing. The first two pictures on the left here, one of them was off of the Johns Hopkins Psilocybin Research Institute website. The picture on the bottom left, the one on the top, is another research center. In contrast, the two pictures on the right are from Immersive PDX, which is one of the centers here in Portland that provides these services. They have in their entryway this giant neon multicolored deer that, if you look up close, is actually constructed out of tiny hand crocheted mushrooms. And then this is one of their treatment rooms, which I think looks amazingly cozy, probably cozier and nicer than my bedroom. So perhaps that's the difference of experience between doing this at a research center and at a commercial center, the overall vibe. All right, so let's talk about a few of these papers. This is interesting. This one was called, Effective Psilocybin Therapy on Major Depressive Disorder. This came out in JAMA Psychiatry back in 2020, got a lot of attention. They were looking at adults who had carried a diagnosis of major depressive disorder and were currently on no medications. The way that this study addressed the issue of blinding and that kind of anticipation or enrollment bias was that they used a waiting list as their control. And how that worked was they enrolled their study group, which was about 30 people, and they told them they would be getting psilocybin, and then some of them had to wait an unspecified amount of time at the beginning until they could start. And when the clock started, they had their immediate treatment group, and then they had that control waiting list group, and they administered the same depression scales to individuals over time. So that waiting group, any of that excited anticipation, but now they're having to wait, that's how they controlled for that. So the groups both had 2 sessions of psilocybin. They received 20 milligrams per 70 kilogram for the first session, and then they received 30 milligrams per 70 kilograms for the second session, and they received therapy in between. They did phone check-ins and, completed these various scales. So if you look at, the graph on the left, this is comparing the control group to the initial test group, and you saw this significant improvement in the test group's self-reported depression scales after they received their sessions, and this persisted to week 8. Then the second graph that we see is when they compared with the control and the test group, and they saw the same pattern. So basically, everybody who participated had a huge improvement in how they answered depression scale questions, and this persisted for at least 4 weeks post-treatment. Nobody had any adverse effects, so this was considered a pretty exciting study. Here's another one that came out not too long after that in the New England Journal of Medicine in 2021. This was a trial of psilocybin versus escitalopram for depression. They enrolled 59 adults, and they were randomized either to receive psilocybin or escitalopram. Their placebo for the escitalopram group was at their treatment sessions. They gave them 1 milligram of psilocybin, so an incredibly low dose, but the hope was that they'd have that very slight feeling of intoxication or sensory alteration enough that they wouldn't know which medication that they had received. So, if you look at the graphs here, basically what this is showing and how this was interpreted and reported was that there was no statistically significant difference between the psilocybin group and the escitalopram group at 6 weeks out in terms of how they improved on their depression scales. Both improved quite a bit. They improved the same. So some people interpreted this as oh, yeah, it's no better than escitalopram. When I looked at this, my first thought was, wow, actually, in my mind, it shows that this is at least as good as escitalopram in this limited evaluation and way of looking at it. And, the authors argue that there may be a trend towards superiority that's just not statistically significant. That could be true. That graph on the bottom, B, was some different scales of just sort of general well-being, and they didn't give full confidence intervals for this one due to some statistical factors, but they interpreted it as a trend towards psilocybin having better overall well-being impact. It's worth noting that, there were sort of similar rates of side effects reported in both groups, but the side effects are quite different. Specifically for psilocybin, people may feel mildly nauseated or acutely anxious when initially feeling the drug's effects, whereas I think, the side effects that people associate with SSRIs are pretty well known, and for some patients can be a real hindrance to adherence. So I think this small study for 6 weeks shows that psilocybin is potentially as good as escitalopram, and for a particular patient, that might be a more appealing therapeutic than a daily SSRI. Switching gears, here is a interesting paper where psilocybin was used for treating alcohol use disorder. They were measuring days of abstinence, days of heavy drinking, and just percent drinking days overall. The way that this one worked, they treated with either psilocybin. Their first session, they got 25 milligrams per 70 kilogram. The second session, they would go up to 40 milligrams per 70 kilograms, depending on how they tolerated their first dose. Their control was diphenhydramine, 50 milligrams. The second session was up to 100 milligrams of diphenhydramine. But they also did psychotherapy over this treatment window and the time that they were following the patients. They also did cognitive behavioral therapy, which of course can be shown to be really helpful with habit changing. But in this study, they showed a statistically significant improvement in all of the items they measured. Specifically, people in the psilocybin group had fewer heavy drinking days, fewer drinks per day, and better adherence to abstinent days than individuals who receive the placebo. This is very recent paper, and it was open label, almost just a trial of concept paper. But I feel like bipolar disorder gets overlooked a lot in these studies for various reasons. So I thought it was worth sharing this particular study that just came out in 2024. They had 15 participants with bipolar disorder who had to be off their medications for 2 weeks. They had 3 sessions with therapists, and then they had an 8-hour treatment session with psilocybin, 25 milligrams, and then they had a few more post-treatment sessions with therapists. So single psilocybin session, lots of therapy. What they were looking at here and calling response criteria was a 50% decrease in the score on the scale that was used here to assess for depressive type symptoms. And then they counted somebody as being in remission if their score was less than 10. So at the 12-week endpoint, 12 of their 15 participants were answering the questionnaire as both meeting the response criteria of a 50% improvement and remission with a raw score of under 10. So that's fairly compelling, right? And, I could go on, and I won't, because there are other things to talk about here too. But I did want to give you just a little smattering of some of the titles of some recently published papers looking in similar ways at psilocybin's application for any number of things. I mentioned that a lot of issue that we find here is that often patients need to be weaned off of all of their medications before somebody can enroll them in a psilocybin study. There is a paper that came out in 2023 that was a relatively short study interval, but they had individuals who were on SSRIs and felt to have treatment-resistant depression, who they did a psilocybin trial and kept them on their SSRIs. All of the patients tolerated it fine. There were not any increases in side effects. There certainly was no serotonin syndrome, and all of these individuals did show that same kind of improvement in self-reported depression scale answers as we see in a lot of these other studies. There was a feasibility study done on patients with anorexia nervosa, which is an interesting group that often, I think, also gets overlooked in a lot of studies. They only had a single session of psilocybin, and they were followed for a number of weeks. And what the study showed was that all of the patients tolerated it well. Nobody had any exacerbations of any depression. And all of these individuals reported feeling calmer for a few days after their session, and they all requested a second session. There's been a study, at least one study, looking at military veterans with severe depression or PTSD. I saw another study I thought was interesting, looking at HIV-related shame specifically. This study had very similar findings to what we've seen. Individuals after 1 or 2 sessions have much better responses to their depression and anxiety scales. Interestingly, there were 2 individuals in this study who reported that in this setting of this study, it unmasked some previously unacknowledged sexual trauma, which sort of provoked them. So that it wasn't that the psilocybin itself caused a worsening of their underlying psychiatric disease, but they became more aware of some things. And interestingly, there's now some speculation and discussion of, can psilocybin be used to treat dementia? I think we're probably a little ways off for a study for this, really looking at it directly, but there's been this flurry of publications kind of looking more closely at some of the mechanisms of the desynchronization of the brain and the impacts it can have on neuroplasticity and forming of new memories and new perceptions. And it's an intriguing idea. I had not previously included this in slides, and have had enough people ask me about applications for dementia. I wanted to at least include the mention of it to know that it's certainly something that's being speculated about. All right. So here we are, all of this research that seems to be finding a lot of potential benefit in the right setting, in a controlled setting. The next question is this safe? I mentioned earlier, I think a lot of us as clinicians probably intuitively just get that psilocybin is not a dangerous drug in the way that we think of, drugs like cocaine or methamphetamine. Like, we don't see people coming into the ER very often at all with psilocybin related issues. And, I can tell you at the Oregon Poison Center, we get virtually no calls about psilocybin, and there has not been an uptick in calls about psilocybin since treatment centers opened in Oregon. In most of these studies, there are really limited adverse effects reported. Sometimes individuals have some acute anxiety as they're becoming symptomatic from the psilocybin. So they'll get a dose of clonidine, a dose of lorazepam, and then be fine. There's often concerns expressed in discussion sections of papers that, could we worsen somebody's depression with this? Can we cause suicidal ideation? None of the studies that I've looked at have found a really reportable rate of this at all. And yet, we also live in a world where weird things happen and media finds out about it. This one, I had to laugh when I found this case report because, I make the following joke as a toxicologist, but it's like, wow, if I swallow something and it makes me high, what happens if I inject? Because things are better when you inject them, right? Well, in this case, no. Somebody tried to inject psilocybin thinking they would get even higher, and they ended up in the ICU with multi-system organ failure. But, perhaps more concerning to lay people and certainly to voters who might be looking at measures on their local ballots, similar to what we had in Oregon, there are things like this. This was, back in 2023 at the Wonderland Festival up in Washington State. There was an individual who pulled out a gun and shot a couple people and ended up sharing that he had been on mushrooms. It made enough National Post to get written up in Rolling Stone. And then, more recently, also making national headlines, was the Alaska Airlines pilot who was riding in the jump seat and tried to deactivate the plane in mid-flight. This is from a New York Times story about this gentleman. What he ended up saying was that he had been trying to self-medicate for depression with psilocybin mushrooms because he felt shame and stigma in the airline industry around depression and didn't think that he could seek care. And while he was sitting on this airplane as a passenger in the jump seat in the cockpit, he began to experience the psilocybin mushrooms and thought that he was having a dream, and that if he could just wake up, he would be at home in his bed. And so when he jumped up and tried to turn off the plane, that was him thinking that that would make him wake up. So is this kind of stuff really going to happen? Do people need to be worried? So I think this is pretty cool. There actually was a study published looking at self-reported adverse effects from using psilocybin. This study data was collected in 2016. This global drug survey, it is something that it's this anonymous self-reported study. They advertised online, on social networking sites. They had media partners advertising it, various harm reduction groups. The survey got, 119,000 responses across the world. And interestingly, of those 120,000 people, 24.5% reported having used psilocybin mushrooms at some point in their life, and 43%, interestingly, had done so in the last year. There was a section on this questionnaire asking about seeking emergency medical treatment for anything. That particular section had 9,200 responses. Of those, there were 19 incidents where somebody said that they had sought emergency medical treatment after mushroom use. Teeny tiny percentage, that's 0.2%, that calculates out to a per event risk of 0.06%, or 1 in 1,800. So very low rate of people feeling like they need to seek emergency medical treatment after using mushrooms. So then of those 19 reports of why they sought emergency medical treatment, here is why individuals said that they did. The majority was because they felt anxious or they became paranoid or thought they were seeing or hearing things. Um, sorry, here we go. Other information they provided, the vast majority of them said that their symptoms lasted for 6 hours, give or take. When asked why they think they had a negative experience, it looks like the majority felt that it was their mindset going in. So maybe this speaks to the benefit of having a facilitator along with you when you're having one of these sessions. And, 7 also mixed it with another substance, which, kind of clouds the picture, right, as far as therapeutic use. So here's a breakdown of the kinds of things that individuals mixed with. So all of that to say, out of this huge data set, a very small number of people who used mushrooms reported feeling that they needed to seek any additional help for it. So I feel like this jives with what we know, right? It's just sort of our gut experience of it. Okay, so a few more things I want to sort of maybe dampen our excitement about what we've seen in the literature with before we move on to talking about what's happening in Oregon. What I'm about to share with you may be my favorite study I have ever read, and I'm calling this the unplacebo effect. What I mean by that is the sort of that enrollment bias or positivity bias that I talked about. Like, how much are we seeing of people really just wanting psilocybin to work for them when they participate in these studies? So it turns out there is actually a psychology lab that is dedicated to studying the placebo effect at McGill University. They published this paper in 2020 called Tripping on Nothing. And yeah, it is my favorite study of all time. So basically what they did was they had 2 separate study groups. They recruited college students and they told them that they were going to be, part of a study looking at the effect of a psychoactive drug on creativity. They told them that it was going to be something called iprocin, which is a psilocybin homologue. And if you were to look it up, it would tell you that, it could improve your mood, it can make you feel more aware, more creative, all of these positive benefits. And they had their 2 groups. They had them show up before the study. They told them what to expect. And they also had some individuals planted in the group who they called in the study Confederates. And these Confederates were, people who looked like college students, and they would say things like, "Oh, wow, I'm really excited to do this. I've heard really good things about this drug." Or, "Oh, yeah, my roommate participated in this 2 weeks ago and said he had this really profound effect." So they set the stage like that. They gave them a placebo pill, basically a sugar pill, and then put them into this room that was sort of this trippy psychedelic space. They had music playing. Here's a picture of like a movie with like monkeys, all of the like neon colors, and had them walking through the room and just sort of hanging out. And then they were periodically administering questionnaires to them about different kind of symptoms and perceptions they were having. Um, Here is sort of the results that we see of people's answers, individual participants' answers of all these different things that they were testing for, like their spiritual insight at the time, their feeling of disembodiment. Now, the black dotted lines on the graph are showing you results from people who had completed these questionnaires at particular doses of psilocybin. What you'll see is, like, if you look at these purple spikes, they're individuals who are scoring higher than a relatively high dose of psilocybin on some of these scales, right? So but they got a sugar pill. So of course there was significant individual variation between participants, but when they asked them at the end of the study, or at the end of the time interval rather, 61% overall reported having had some effect of the drug. With their second group, they actually asked them right before they went over the results to like say how certain they were that they'd had a drug. Um, you know, 35% of their participants said that they'd received a placebo, but 53% truly weren't sure. 12% of the participants were absolutely certain they had received a psychedelic. And apparently there was one individual in the study, I'm assuming it's the one who had all these like the purple scoring off the chart scales, who argued with the testers, insisted that they had had a very profound experience, and then ended up asking if they could get some more of the sugar pill because they felt like it was something that really helped them. So cool study demonstrating the power of the mind. And just following up on that, I want to throw in this slide on this like small but interesting study looking at microdosing. Microdosing is the idea that's really been popularized a lot lately. I think in just sort of popular media about taking very low doses that are felt to be sub-perceptual, meaning they don't impact your ability to interact with the world. So low doses of psilocybin mushrooms to enhance your general well-being and creativity and performance. There are a lot of studies that suggest that it can have this effect, but there's always a limitation of this sort of positivity or enrollment bias. So this small study was trying to do the best they could to blind it and do a placebo-controlled trial. They had two groups. All of the people they enrolled were people who were planning to start microdosing because of purported benefits, and who were willing to put off starting that to participate in the study and to follow the study's protocol. So all of the individuals had two separate weeks where they were treated with either a moderate dose of psilocybin or a placebo, which was made of just a dried edible mushroom. They received one or the other spread out in time, and then over in the week of each study, they had two doses, and then all these different measurements were taken. They did EEGs to see brain function, but more importantly, had the participants answer this VAS scale about depression, some scales about their general well-being, creativity-oriented tasks, etc. And these were their results. Basically, what they found was that acute effects were generally more intense, but it was all tied to if people knew what they were taking or not. When they talk about blinded or unblinded, each week of the study, before they did data analysis, they asked individuals, do you think you got psilocybin this week? Do you think that you got the placebo? 75% of individuals correctly identified, but 25 didn't. The individuals who could correctly identify whether or not they got psilocybin, that's what you see on the left, that group, the psilocybin groups or the psilocybin weeks, showed improvement on the depression scale compared to the placebo. But the individuals who couldn't tell which one they got didn't show any statistically significant difference. And also, when they looked at, I know there's a lot going on in this little picture, but when they looked at all of these different scales of creativity and well-being, basically people performed no differently when they had the placebo or not. So another study showing that your investment in it, your desire to have success, may be impacting psilocybin and how it works. All right. I know I'm kind of getting close to time. I want to take just a few minutes to talk about what's going on in Oregon. Of course, back in 2020, we had the Psilocybin Services Act on the ballot. It was Measure 109. This was when Oregonians got to vote if they wanted to have the Oregon Health Authority set up this agency to develop a treatment model and an industry around psilocybin here. It was wildly popular. It was endorsed by essentially everybody. And the only group that really came out as a no endorsement was one of the sub branches of the American Association of Psychiatrists, saying that there just wasn't enough evidence yet. The measure passed, and you can see there's sort of a clear divide as for what part of the state was pro and what wasn't. And this was at the same time that Measure 110, which was a measure for decriminalizing drug possession, basically passed. So there we go. So what did this mean? This means that the Psilocybin Services Act became a thing in Oregon. That meant that the Oregon Health Authority was going to set up this panel to license and regulate production of psilocybin products and the provision of psilocybin services. And what that meant was psilocybin services offered underneath this framework are legal in Oregon. Anything outside of it is still illegal. Psilocybin product can only be provided to clients at the psilocybin service centers during an administration session and have to be ingested on site. And, I'll kind of reference this throughout this discussion. Psilocybin services are designated as a health and wellness option in Oregon. Always very quick to specify that they're still federally illegal and it's still a Schedule I substance. So we have to keep that in mind. So an advisory board was formed. They had a 2-year plan to kind of work out all the details of this. This was the original advisory board. And you'll see a theme throughout of this effort to have this not be overly medicalized. There were 3 physicians, 1 psychologist, and 1 naturopath in the group. Everybody else were non-clinicians. They're people from law enforcement, people just from the community at large. The group came together to set up an administrative branch, the psilocybin services branch, to establish the regulatory practices. And in 2023, it was all set to launch. So there are 4 aspects of licensing: manufacturing, laboratories, service centers, and facilitators. The way it works is that product must be cultivated and produced, not preceded, sorry about that, by a licensed manufacturer. Part of the provision here is that only natural products are allowed. We are not using pharmaceutical psilocin as are done in some of those studies. It has to be mushrooms grown in Oregon. The mushrooms will be tested by a licensed laboratory in state to ensure quality and consistency. Once tested and confirmed, the product is packaged and then sent to a licensed service center. And then that product would be consumed on site during a facilitated session, which is facilitated by a licensed facilitator. So how are we doing on numbers? This is from earlier in the month. You can check on the OHA's website. Weekly, they update their data. Something I think is interesting, if you look at the top, it looks like they've denied a whopping 2 applications since they started for service centers. And it looks like at the moment we have 34 service centers in the state of Oregon and 442 facilitators. So by the way, if anybody is thinking about a career change here, here's what you have to do to be a facilitator of a psilocybin session. You have to be over 21. You have to have graduated from high school. Prior to this year, you had to be an Oregon resident. It turns out that that is actually no longer the case. You have to pass a criminal background check, complete a training exam, and pass an exam. Not the most rigorous requirements from the start. This is something that I think caused some head scratching. And here is off of the OHA's website, their sort of core requirements from a training program. I know there's a lot up here, but, of course, looking at things as a physician, an emergency physician, and a toxicologist, my eyes immediately go to level or item D, which is the pharmacology, neuroscience, and clinical research gets 4 hours total out of the 120 hours that are required for training. Whereas item A, historical, traditional, and contemporary practice, gets 12 hours. And, cultural equity gets 12 hours. So I mentioned, you can see there's a real earnest, big efforts to make sure that this is something that is inclusive and respectful of cultural traditions, and trying to honor psilocybin's role in Indigenous people's practices. And there's not a ton of focus on the actual medicine of it. And we see this in some of the language that continues through various publications. The Oregon Psilocybin Services Act is not intended to create a medical or clinical model, and the term therapy is used like with a lowercase t, right? They're not defining what therapy is. Facilitators are supposed to take a non-directive approach and be very passive. And something that I think is interesting and surprising to some folks is that individuals who become facilitators who have other kinds of qualifications, like maybe they're a psychiatrist, they're a psychologist, they're a counselor, they are not allowed to practice or utilize any of those skills during a facilitator session. That would be considered out of scope. So very kind of limited there. Somebody just recently put out a study just looking basically at information available online, and also having some questionnaires completed by facilitators about their training programs. So at the moment, there are 16 training programs out there. Half of them have diversity scholarships. The mean tuition, however, is $9,359. So unsurprisingly, the majority of individuals felt that this was a pretty severe financial strain. Partly as a result of that, the mean planned session price they reported was almost $1,400. And this is where, I have to add, this is not a health treatment, this is a wellness option. So health insurance isn't something you can use. So the mean planned cost of an individual who decides they want to try psilocybin through a treatment center is going to be on the order of thousands. And in fact, in May 2023, the first treatment center opened in Eugene, and here are their prices. So they scaled their pricing based on how much psilocybin you got, and if this was an individual or a group. But an individual session with a high dose is $3,500. And that's obviously a lot. So if you just pause and think, like, what's going on here? So much time, energy, and effort put into trying to make this inclusive and accessible and respectful of Indigenous practices. And here we are with something that facilitators have to possibly go into debt for their training. And then people who want to take advantage of this are going to have to pay a few $1,000s. So immediately it's clear that the majority of people probably aren't able to take part in this. And at the other side of the spectrum, in 2022, there was a midterm election sort of option put locally on several ballots, allowing places to opt out. And what that meant was that a county or a town that was unhappy with psilocybin becoming an option here was able to have locally a decision made to opt out of it. And basically, only 4 counties of the 27 who voted on whether or not to opt out chose not to opt out. And what this means is that, yeah, we have this model where we can offer these services, but the majority of counties in the state aren't going to be offering it. Now, the areas in green are where it's going to be offered, and of course that correlates with urban centers and population centers. We see the major divides along rural and urban lines, but nonetheless, it's sort of an interesting pushback. So there we go, 1 minute before the end. These are just kind of my final thoughts. It's a little bit of a bummer note to end on, but the accessibility of this program here is incredibly cost limiting, putting aside anything else that we're talking about here. Most people can't afford this. And in fact, Recently there was a study in sort of national news that there are some centers that were starting to close because their operating costs were just not sustainable. Also, it's like, who's getting these sessions? There is almost like a psilocybin tourism popping up where people with money to burn who are curious from other states might fly into town, have a session, and then leave. Is this serving Oregon? Um, Asking that question rhetorically, nonetheless. Number two, appropriation. I mentioned a little bit of this, but what I didn't mention was that in most of these studies that are being done, there are a couple drug companies that have made their proprietary psilocin that they're now making available for studies. So if this were to become a licensed prescribable therapeutic, who's going to benefit? Well, clearly those drug companies are going to jump on it. And here we have, is the medical community and the scientific community now getting excited about something that's been known and established in certain cultures for centuries, millennia? Are we now just trying to make money off of it? And then finally, this question of these very extremely controlled trials, do they generalize to the real world? So that's kind of where I will leave this topic. And here we are.
Thank you so much, Shana, for that incredible presentation. That was so thorough and gave us a lot to think about. I think we're just going to take one question, if that's all right with folks. I know we're a minute over, but let's take one question and then we're going to wrap it up. Okay, there you go.
Unshare my screen.
There you go, Annie.
Thank you. Okay. So one question, what do you see as the future of research and treatment? Also, would more widespread, higher volume of availability and adoption of treatment drive down costs and increase affordability?
Yeah, so two very good questions that kind of, split. I think the research is just exploding right now. I didn't even scratch the surface on, these various topics. What I think is interesting, this wall that we bump up against almost immediately for any of this, is that it's still technically a like Schedule 1 substance, meaning that it has been designated by the DEA as having no legitimate medical application. And I think until we figure out how to get past that piece, it's all kind of not for nothing, but there isn't an actual clinical application, right? Because people can't use this medication or this substance clinically. So maybe that's not directly answering the question about where things are moving, but like, especially now that people are talking about and proposing some reasonably plausible mechanisms for treatment or even prevention of dementia with psilocybin, like, I'm just curious, what is it going to take to have this come off of the illegal drug list and become a potential therapeutic? We've seen marijuana slowly kind of work its way into first being accepted for medical use and then being legalized in general. I think the question of legalization and safety is different than clinical utility and appropriateness for that. So huge, very challenging thing to untangle. And then in terms of, could costs go down if demand goes up? Which part is like the key log, so to speak, in the log jam? What's the thing that you pull out to then make it more accessible? I think that this model, it's easy for me to sit in my chair and say the model that was come up with to try to have this be a way to generate revenue and kind of regulate things in Oregon is very thoughtful, but the practical application is not proving to work the way we wanted it to. And I think part of the hurdle is this thing where it can't yet be designated health intervention, so health insurance can't cover it. So I just don't see, when we have these expensive training programs and very heavily regulated mushroom. Like, I hear people make jokes all the time, like, why don't you just go buy some mushrooms and go sit in the woods and have a trip? Like, I think there's a clear benefit to approaching it very clinically like this, with a regulated dose in a setting where you're having a facilitator and a guided session with a clear goal. That's different than somebody just doing shrooms and walking around in the woods. And yet you have to be somebody who has that money and those resources available to you.
Absolutely. Thank you, Dr. Kusin. And thank you to everybody who's still with us for joining us for this special National Poison Prevention Week presentation. Please keep an eye out for a follow-up email that will include a brief survey to gather your feedback about today's presentation and an opportunity to suggest topics for future lectures. Have a great week, everyone. Thank you.